on antihypertensives comes with a head injury. So how do you apply this knowledge about the graph between cerebral perfusion pressure and cerebral blood flow in patient? Did you understand my question? Lahiru, you're in the top of the list, so I'm going to ask you. Lahiru,
Yes, sir.
what can you tell? How do you apply the knowledge of this graph when you are dealing with a head injury patient who is 70 years old and who is hypertensive for 10 years? මේ තේරෙන්නේ නැත්නම් සිංහලෙන් හරි අහන්න හොඳේ මම දන්නේ ඕන එකක් අහන්න සිංහලෙන් හරි ඉංග්‍රීසියෙන් හරි So if you consider the graph between CPP and cerebral blood flow in a patient with hypertension, is it the same or is it different? Can you remember your physiology? මේක මේ විදිහටම තියෙන නැත්නම් වෙනස්ද? මතකද? ලහිරු?
I remember, sir.
Can't remember?
Yes.
Okay. So I'll tell. So in a patient with hypertension, these graphs usually shift to the right. So this plateau pace will not start from. So in a normal patient, it starts from 50 and goes up to 150. But in a patient with hypertension, this will shift to the right, to this side. So the plateau will be usually like further to the right. It can be from 60 to 175, like from here to here, or from 75 to 175. So it will be going to the right. So importance of that concept is in a head injury patient, the cerebral perfusion pressure. The cerebral blood flow becomes pressure dependent because of the blood-brain barrier is destroyed. So because of that, in order to maintain adequate blood pressure to the brain, in order to prevent ischemia, you have to have a higher mean arterial pressure because curve is shifted to the right. Say in a normal patient, if you target a mean arterial pressure of 60 or cerebral perfusion of 60, that's the usual value which is needed for optimal perfusion of the brain in normal patient. So if you target a cerebral perfusion pressure of 60 to a hypertensive patient, it can result in cerebral ischemia. So because of that, you need to target a higher cerebral perfusion pressure for a patient who is hypertensive for maybe 10 or 15 years. Is that clear? Lahiru? ඒක තේරුණාද?
Yes, sir.
Lahiru?
Yes, sir.
Okay. Is that concept clear?
Yes, sir.
මේක මේ තුනේ මොනවද ප්‍රශ්න තියෙනවද කාටවත්?
Sir, I have a question.
ඔය ජීවන්තද?
Ashan.
හා.
What is the difference between cerebral perfusion pressure and cerebral blood flow?
So cerebral blood flow is the flow. Cerebral perfusion pressure is a pressure. So if you want to have a flow, say there are 2 points. One, there should be a pressure difference, isn't it? In order for a flow to happen. So
Yes.
Perfusion pressure is the pressure which is like sort of the pressure difference. So think of it as a pressure which is needed for the blood to go into the brain. So CBF is a flow, CPP is a pressure, isn't it? So the name itself makes a difference now. Is it clear?
Yes, sir. Clear, sir.
Okay. Any other problems?
Sir, the blood vessels shown in the graph in the above, they have a relationship with the 3 graphs.
Yes. So, okay, I'll explain that as well. I didn't go into detail of that. So, if you can see, say, just forget the relationship, forget the orange and blue graphs. Just concentrate on the green graph, okay? So, if you consider from 50 to 150, the cerebral blood flow remains constant. Okay. So
Yes.
at 50, say roughly at say around 60, the blood vessel is maximally dilated. Okay. And if you
Yes.
look at 150, it's maximally constricted. Okay. So when the pressure decreases, in order to maintain the blood flow at a constant level, the blood vessel maximally dilates. And when the pressure increases, as you can see when you go to the right, in order to maintain the cerebral blood flow at a constant value, the blood vessel constricts. Okay. Say if at the right side, if the blood vessel is maximally dilated, when the cerebral perfusion pressure increases, the blood pressure will also increase. So you will not get a graph like this. In order to maintain the plateau, when the cerebral blood flow, when the perfusion pressure decreases, the diameter increases, and vice versa. When the cerebral perfusion pressure increases, the radius decreases in order to maintain this constant level.
Oh, sir. Thank you.
Sir, there's a question.
Oh.
In graph, x-axis is also cerebral perfusion pressure.
Oh.
And the pain graph also, what's the difference between them?
So because this, there are three graphs, there are two axes, two x-axis is named with different things. So when you deal with the the green graph, you have to consider CPP. And when you deal with the other two graphs, you have to consider the partial pressure of oxygen and carbon dioxide.
Okay. Right.
When oxygen, oxygen. අපේ blood gas එක ගෙවුවොත් කීයද partial pressure of oxygen? ඔය blood gas එක ගෙවුවොත් කීයක් විතර වේද? Usually it's around 100, right? If it varies with the age, say you do a ABG in a patient who is 80 years, it might be like 85 to 90. So you can take it as normal. Actually, the partial pressure of oxygen depends on the age. There's a formula. You don't have to know. The bottom line is you have to know that if it can change with age. In an elderly patient, it can be like less than 100. Usually, if you do a blood gas in you and me, it can be around 100, but it changes with the age. Shall we move on? Good question, Tava. Okay. So next graph is the relationship between intracranial volume and intracranial pressure. Chamatka, can you describe? Chamatka,
Yes, sir.
What can you see from this graph?
When intracranial volume increases, intracranial pressure remains same, slightly rise in A to B and drastical rise.
Okay, fine. So as you said, initially from A to B, it slightly rises, or more or less you can say it's constant. And from B to C, it rises a bit, and from C to D, there's a drastic rise. You call this an exponential rise. So what's the clinical importance of this? Roughly, this drastic rise begins when the intracranial pressure is around 15, right? 15 to 20. So in the y-axis, the point C corresponds roughly to a value of 15 to 20 millimeters mercury. Okay. And what's the importance of this? So I'll just describe it. So as you can see, do you know the Monroe-Kelly doctrine? Can anybody remember the Chanika Beratna? Do you remember the Monroe-Kelly doctrine?
No, sir.
Okay, Chanudi. Chanudi, can you remember the Monroe-Kelly doctrine? Okay, Chaturi.
No, sir.
Chaturi.
Sir, it says the intracranial volume is constant,
Okay.
almost constant, and it cannot expand.
Okay. Okay, fine. So that's roughly what it means. So, the skull, the cranium is a rigid box, and the contents consist of CSF, blood, and brain matter. And if one component increases in order to maintain the intracranial volume constant, the other component should decrease.
Yes.
Intracranial So these are the contents in the cranium. It consists of the venous blood, the arterial blood, the brain matter, and the CSF, right? So normally normally the body tries to maintain whatever parameter at a constant level. As I discussed earlier, the body tries to maintain the cerebral blood flow irrespective of the changes of cerebral perfusion pressure at a constant rate, right? In the same way, the body tries to maintain the intracranial pressure at a constant rate irrespective of the changes in its contents. So there are certain adaptive mechanisms. So when the intracranial pressure rises, say as for an example as shown in this graph, there's a mass in the second graph, which say you can attribute it to a blood clot. Say somebody comes who has been also assaulted to the head with a pole, and there's a blood clot developing inside the brain. And in order to maintain the intracranial pressure, the venous blood and CSF is initially displaced. Actually, the venous blood is displaced, and subsequently CSF is displayed. Actually, the two can happen at the same time. So because of that, initially when the intracranial volume increases, the intracranial pressure doesn't change because venous blood and CSF is squeezed out of the cranium. Okay, so that's the importance of this initial part. In a normal patient, the intracranial pressure will be maintained at a constant rate in spite of changes in the intracranial volume, right? So what's the problem if the intracranial pressure increases? Body tries to prevent that increase, and what's the importance of that?
To maintain cerebral perfusion because of cerebral
Yes,
blood.
so that's right. So one thing is in order to maintain cerebral perfusion. Cerebral perfusion samanai MEP minus ICP. ICP cerebral perfusion, the cerebral perfusion pressure decreases. What's the other importance? If the ICP increases, one thing is CPP, cerebral perfusion pressure will decrease. Other thing is what?
Brain herniation.
Yeah, it can cause brain herniation and can cause death. So there are vital structures in the brain stem. So there is one thing called uncal herniation and etc. So because of that, ultimately it can result in death. There's a certain mass venous volume CSF, it reaches a maximum level which it can compensate. So after that, after point C, so up to BC, there's a little increase in intracranial pressure. The body, however, tries to maintain the intracranial pressure at a constant range, constant value. But after C, there's a dramatic increase because the compensatory mechanisms are overwhelmed. හරිනේ? මාස ගඩියනකට මේක දතා විනස් වොලියුම් එක CSF එක දාන්න දෙයක් නැති වෙනවනේ. ඊට පස්සේ මුංගාල මේක නගින ඩෝංගාල. හරිනේ? Are there any questions from these three graphs? So what is the importance of knowing this value of 20? I told that the intracranial pressure will begin to rise at a value of roughly 15 to 20 when the intracranial volume increases. Can you think of how can we attribute this to our clinical practice? ඒක මොකද clinical importance එක? දනුංග මිහිරාන් කියපල.
We should maintain the 20.
Okay, so that the importance is we should not allow the intracranial pressure to rise more than 20. Okay. So in order to maintain, say there's a head injury patient, and in order to maintain a decent cerebral blood flow, what should be the minimum mean arterial pressure if we don't know the ICP?
Around 100. Around 150.
That's cerebral perfusion pressure. If you target the mean arterial pressure, what's the mean arterial pressure that you should target?
90
if you want
170.
No, what's the minimum? Then what I mean?
90.
19 maybe. How do you put this clipboard? Share. Whiteboard. Share. Can you see this whiteboard?
Yes, sir.
CP equals mean arterial pressure minus ICP. Okay, so so the maximum value of ICP we can allow is 20, isn't it? Right? So roughly, as you can remember if you can remember the graph, in order to maintain a decent cerebral blood flow, we have to target a minimum cerebral perfusion pressure of 60. So if
Yes,
you
sir.
want to maintain a cerebral perfusion pressure of 60, the minimal max that you should maintain is 80.
80.
That's the reason. So in a patient with head injury, the blood-brain barrier is not intact, and in patient with head injury, the cerebral perfusion, this part, cerebral perfusion pressure depends on the the cerebral blood flow depends on the cerebral perfusion pressure. So this is related to so this is related to cerebral blood flow. That's why we are worried about cerebral perfusion pressure. CPP minimum එක 60ක් තියෙන්න ඕනේ. ICP අපිට allow කරන්න පුළුවන් maximum ගාන 20යි. එහෙම වුණොත් එහෙම අඩු ගානේ 80ක් තියෙනවනේ mean arterial pressure එක. cerebral blood flow එක constant තියාගන්න. නැත්නම් adequate cerebral blood flow එක තියාගන්න. ඒක හරිද? Did everybody understand? That's why if there's a head injury patient, we are so much worried about increasing the blood pressure, maybe by putting a central line and putting noradrenaline or giving fluids, etc., etc. Okay, that's the concept of that's why actually you need to increase the cerebral the mean arterial pressure in a patient with head injury in order to make sure that you maintain adequate cerebral blood flow because of this relationship. Are there any questions?
Yes, sir. Then what about the BP of this patient?
Oh, BP can be mean arterial pressure. දැන් මේ map කියන්නේ මොකද්ද? map එක හදන්නේ කොහොම සමීකරණයක් තියෙනවනේ?
Yes, map equals to diastole plus 1/3 of pulse pressure. So I really would like to know the BP of this patient.
So the BP depends. Now, okay, I'll explain that. So if you want to maintain, say if the blood pressure is 120/80, what would be the mean arterial pressure? Roughly? Toggle hadal bala?
93.
93 there. Okay. So if it's when you so since we are having automated blood pressure machines, the mean arterial pressure will usually be displayed in the machine, right? So if the systolic blood pressure is 90, I would say there's a patient with head injury who comes after an assault, and because of the bleeding, the blood pressure is 90. Say the blood pressure is 90/60. Then we know that the cerebral perfusion, the mean arterial pressure is less than 80, right? So by looking at the mean arterial, in our practice, we have these automated machines. So when we resuscitate the patient, we always look at the mean arterial pressure, like give fluids and see how the systolic blood pressure goes up, and look at the mean arterial pressure. Did you understand?
Yes, this.
Actually, we can't, in our day-to-day practice, we can't do calculations when we do the clinical practice. Since we have in the automated machines, it displays the mean arterial pressure. So once we increase the systolic blood pressure with resuscitation, either by giving NORAD or fluids, the mean arterial pressure will automatically go up. So we actually don't target a certain blood pressure. We always target the mean arterial pressure. Okay.
Okay, sir.
And as you raise that point, the new guidelines say that because of this inconvenience in targeting mean arterial pressure, that's easy to target systolic blood pressure. So if the patient has systolic, in young patients, they are asked to target systolic blood pressure of at least 110, and in elderly patients, when it goes up to like 120 to 130, because of this problem in sometimes the practical difficulties in maintaining, knowing the mean arterial pressure because of convenience. So for FTO level, just know that a mean arterial pressure of at least 80 is needed to maintain minimum cerebral blood flow. Okay. Any questions after that? Okay, we'll quickly go on to the next point. Otherwise, we'll be dealing with only physiology. So next part is about primary and secondary brain injury. Okay. So can anyone tell me what is primary brain injury?
It's brain injury occur at the time of the injury trauma.
Okay, that's right. So it's the initial insult to the brain. For example, if somebody hits with a pole to the head, there'll be certain changes inside the cranium. That's the primary brain injury. Or say if somebody meets with the RTA, the changes occurring at the site or within the initial few hours, that's the primary brain injury. And can anybody tell me what happens in primary brain injury? I know it's a bit complex. Do you know what happens in primary brain injury? Like if you consider the contents inside the cranium, you can tell. So I have a small slide for that. I'll describe it. Can you see this one?
Yes, sir.
Okay, so primary brain injury is the injury which happens within minutes to the initial few hours. So if you can see, there are mainly three mechanisms. Like if you can see, the end path is increase in ICP because of primary brain injury. So which will ultimately decrease the cerebral perfusion pressure. That means the blood flow to the brain and cause ischemia of the brain. Or because of the raised ICP, it will cause herniation of the brain contents. Okay, so primary brain injury, the final common pathway is raised ICP. So if you take the left-hand side, because of the primary brain injury, there is damage to the cerebral blood vessels. Okay, which can be either venous or arterial. It will cause bleeding, and when there is bleeding within the cranium, the blood itself acts as a stimulant for vasospasm. Okay, it's highly irritable. Because of the vasospasm, it will. Sorry, this is cerebral perfusion pressure, not ICP. Sorry. So because of the vasospasm, it will decrease the cerebral perfusion pressure, which will ultimately cause cerebral ischemia. Okay, primary brain injury, damage to cerebral blood vessels, will cause bleeding. The blood itself is very highly stimulant for vasospasm. Because of vasospasm, there will be reduction in cerebral perfusion pressure. Okay. Then there's another pathway. Because of primary brain injury, there will be damaged blood vessels, will cause bleeding, will cause a focal hematoma. So there will be a blood clot inside the cranium. So because of that, there will be increase in ICP, like this one. This is a normal one. Somebody comes after assault, there's a blood clot, it gradually expands and will cause raised ICP. Okay. So then the next one. Because of primary brain injury, there will be diffuse axonal injury and focal contusions. Focal contusions is there will be, because of the assault, there will be damage to the brain matter. What do you mean by diffuse axonal injury? Can you remember? It was taught in, I think, forensics, isn't it? මතකද ඒක?
Yes, sir.
කියන්න බලන්න.
Due to the shear forces, because there are the brain has different medias, they move in different planes, so the axons which go through them will get very minor injuries, and
okay, that's right. So okay. So because of the relative movements of the planes of the brain, there will be damage to the axons, and it will result in damage. So that's called diffuse axonal injury. And in clinically, sometimes the CT, if you do a CT in a patient with diffuse axonal injury, if the CT brain might mean CT brain can be like completely normal, or when it evolves, if the insult is severe, there can be loss of gray-white differentiation. Okay. And because of the diffuse axonal injury and focal contusions, there will be neurotransmitter release, like various neurotransmitters will be released, and there will be three things which will lead to that. One thing is vasogenic edema, other thing is cytotoxic edema, and other thing is apoptosis. Because of the neurotransmitter release, vasogenic edema is edema related to the vessels, and there will be leakage of contents from the blood vessels, and it will result in increase in ICP. And because of cell swelling, cytotoxic is related to cells, it will cause raised ICP, and apoptosis is cell death, which will also result in increased ICP. So ultimately, because of primary brain injury, in one aspect, it reduces cerebral perfusion pressure and causes cerebral ischemia. And on the other hand, because of raised ICP, it will initially cause cerebral ischemia by reducing the cerebral perfusion pressure, which ultimately will reduce the cerebral blood flow. or else it can cause herniation syndromes, which will ultimately result in death. Okay, so with regard to primary brain injury, can we do anything? Dilusha, Dilusha.
Yes, sir. We can't do anything.
Okay, we actually can't do anything because the insult has already happened. Okay.
Yes, sir.
Okay, next. This is the most important thing. Like other part, it's nothing. If you know the cerebral physiology and about cerebral blood flow and ICP, you can easily work out the rest. And what are the, like, because of cerebral vascular injury, what are the injuries that you can see clinically in clinical practice? Gayatri Somavira. Gayatri. Sabdyan. Hashan. Hashan Gambala. Hashan innada? Itna. HHJ innada? Himasha. Huawei Y7 Pro, iPhone, Ireshika. Okay, can somebody tell me what are the different clinical pictures you can see due to cerebral vascular injury or different injuries you can see due to cerebral vascular injury?
Subdural, subarachnoid hemorrhages, hematoma.
Okay, subdural. So if you take from the outermost, you can get extradural, then subdural, then you can get intracerebral bleeds, and you can get traumatic subarachnoid hemorrhage. Okay. EDH again, what's the culprit vessel for EDH? Is it arterial or venous?
Arterial.
What's the commonest artery?
Middle cerebral.
Middle
cerebral. Okay. Subdural, why do you get subdural? You tear off
bridging veins.
Okay, bridging veins. Okay, and subarachnoid?
Circle of Willis.
Circle of Willis. Berry aneurysms.
Or rupture of berry aneurysm. So it's due to arterial beats, right? Because the blood vessels, the arteries travel in the brain within the inside the CSF, isn't it? Covered by the layers. Okay. So that's about primary brain injury. And how can you remember the different patterns you can see in the CT if you get a EDH, SDH, or intracerebral bleed or subarachnoid hemorrhage? In EDH, you get a convex pattern, isn't it? Neither?
Lens-like, yeah.
Yes,
Yeah.
sir.
Yes, sir.
Slide the EDH එකෙන් මෙහෙමනේ. මොමයක් කියන්නේ නේ? හරිනේ? මිඩි පාට කළා. SDH එකෙන් කන් කේව් එක නේ මෙහෙම එක. හරිනේ? ඊට පස්සේ focal contusions out contusion intracerebral එකේ එහෙම සුදු පාට තියෙන්න පුළුවන් එක තැන් වල. Okay.
Yes, sir.
And if it's a traumatic subarachnoid hemorrhage, you can see blood within the ventricular system. Ne, ventricular system blood. Okay. So that's about primary brain injury. Okay. Then let's move on to secondary brain injury. What is secondary brain injury? If you have questions, you can type and send. Okay. If you are like shy to ask any questions, just type and send. Could you please explain a little about CO2 and O2 graphs again? I'll explain. Don't worry. I didn't see this question. Sorry. Okay, let's move on. Second brain injury. What is second brain injury?
Injuries that occur due to increase ICP and decrease cerebral perfusion pressure.
Okay, that's right. Second brain injuries, the changes in the brain or the damage which occurs after maybe hours, like it's the damage which occurs after the primary brain injury. So as you said, one thing is one of the reasons for second brain injuries, one thing is reduced oxygen delivery. It can occur due to various things. Other thing is increased oxygen consumption. So I'll tell some examples. Then it can be due to cellular mechanisms. So there are mainly three aspects which will lead to secondary brain injury, right? One thing is reduced cerebral oxygen delivery. Other thing is increased cerebral oxygen requirement. And other thing is cellular mechanisms. So one thing is, the first thing is reduce cerebral oxygen delivery. Say there's a head injury patient who comes after RTA. What are the mechanisms which can lead to reduce oxygen delivery in that patient? So the oxygen delivery to the brain depends on the content of oxygen in the blood and the cerebral blood flow, isn't it? So there should be oxygen in the blood, as well as there should be a adequate blood flow to the brain in order to deliver adequate oxygen, isn't it? So any of the mechanisms which will reduce the cerebral blood flow or the oxygen content in the will lead to reduced oxygen delivery. Is it clear?
Yes, sir.
කාටත් තේරුණා නේ?
Yes,
Okay. So secondary injury කියන එක තේරුන්නේ නැහැ. Secondary injury කියන්නේ දැන් primary injury එක වෙලානේ තියෙන්නේ. Primary injury එකෙන් පස්සේ වෙන damage එක තමයි secondary injury කියන්නේ. තදුල අමරසේකර. හරිනේ? තදුල හරිද? Primary injury කියන්නේ මුලින්ම වෙන injury එක. ඒ කියන්නේ දැන් පොල්ලකින් ගැහුවා කියමු කාට හරි. කෙලින් blood vessel එක rupture වෙලා මේ hematoma එකක් හැදෙනවා. ඊට පස්සේ එක changes වෙනවා. ඒක තමයි primary brain injury එක. Secondary brain injury කියන්නේ primary injury එකට පස්සේ වෙන ටික. ඒක events වෙලා වෙන එක. හරිද? හරියද මන්ද?
හරි සර්.
හරිද? රදුල? Okay. So as I told, there are three mechanisms. One thing is reduce cerebral oxygen delivery, which will cause secondary brain injury. Okay. So reason for that is any reason which will decrease oxygen delivery to the brain. So oxygen delivery to the brain depends on adequate cerebral blood flow and an adequate content of oxygen in the blood. So any factor which will reduce the cerebral blood flow will lead to reduced oxygen delivery, which in turn will lead to second brain injury. Cerebral blood flow අඩු වෙන මොනවද? එකක් තමයි there is inadequate mean, if we can't maintain adequate mean arterial pressure. Say there's a patient who comes after RTA, and in addition to the head injury, he has a bleed from the femur fracture. So because of that, he will lose lot of blood, and the intravascular volume will be reduced, and because of that, he will be unable to maintain adequate mean arterial pressure. Because of that, ultimately, there will be reduction in cerebral blood flow. And in the same patient, okay, and in the same patient, because of the blood loss, there will be loss of hemoglobin. If there's loss of hemoglobin, the oxygen carrying capacity will be lost in the blood. So which in turn will result in decreased oxygen delivery to the brain. So that is one thing is volume loss, and because of volume loss, there will be hemoglobin loss, and there will be reduction in content of oxygen in the blood. Then what are the other factors which can lead in reduced oxygen content in the blood? One thing is there can be problem in the lungs, or another thing is when there's problem in the lungs, right? If there's aspiration or if there's damage to the lungs, if there's a pulmonary contusion, a hemothorax, pneumothorax, there will be reduction in delivery of oxygen from the atmosphere to the lungs to the vasculature, which will ultimately result in reduced oxygen delivery to the brain. So hypoxia due to pulmonary problems can lead to second brain injury. Okay. Haridega, any questions about that? So one thing is volume loss, which will lead to anemia because of loss of hemoglobin, and which will lead to hypertension because of loss of volume. The other thing is hypoxia due to pulmonary problems, due to aspiration, pneumothorax, hemothorax, then due to hypoventilation, maybe because of head injury. And then because of reduction in cerebral blood flow due to increase in ICP. So these factors will lead to reduction in cerebral oxygen delivery and to secondary brain injury. Then second thing is due to increased cerebral oxygen requirement. So that happens either because of increased requirement. One thing is due to seizures. If the patient is fitting, it can lead to increased oxygen requirement. Then other thing is due to fever, temperature. If the patient is hypothermic, say if the, on top of head injury, if the patient gets infection, say if the patient is septic, then the temperature will rise and it will result in increased oxygen requirement, which will ultimately result in secondary brain injury. Then the third thing is cellular mechanisms. As I explained in this graph, there are various cellular mechanisms which will lead to primary brain injury as well as secondary brain injury. One thing is mainly due to release of various neurotransmitters, and other thing is due to hyperglycemia and due to free radical damage. So all of these will lead to secondary brain injury. So the importance of knowing the mechanisms of secondary brain injuries, that because it's preventable, so we have to take all the measures in order to prevent secondary brain injury. We have to stop the mechanisms which result in reduced oxygen delivery. We have to stop the mechanisms which result in increased cerebral oxygen requirement, and we have to stop the mechanisms which result in secondary brain damage from cellular mechanisms. So in order to stop the mechanisms resulting in reduced cerebral oxygen delivery, we have to maintain a decent mean arterial pressure. If the patient has lost volume, we can give volume. We can give either crystalloids or blood. Okay. And say if the patient is anemic, we can give blood in order to increase the hemoglobin in the blood. If the patient is hypoxic due to lung problem, we can give oxygen to the patient, supplementary oxygen, or we can intubate the patient and ventilate, because ventilation can improve the oxygen delivery substantially to the patient, like by various things, by adding PEEP, by changing the tidal volumes, by adjusting the respiratory rate, basically by taking the ventilation into our hands. And to reduce the intracranial pressure, if the intracranial pressure rises, in order to prevent secondary brain injury, we can do various things. Say if there's a big extradural hemorrhage, we can do a craniotomy and remove the clot. If there's a big subdural hemorrhage, we can do the same thing. We can do a craniotomy and remove the clot. So by those mechanisms, that's why, say there's a patient with extradural hemorrhage or subdural hemorrhage who comes to the hospital, and if his GCS drops, that's why we quickly take him to the operation theater and evacuate the clot in order to maintain the intracranial pressure and to prevent secondary brain injury. Okay, so that's basically about secondary brain injury. Any more questions? Primary brain injury, we can't do anything. Bottom line is primary brain injury, we can't do anything. And for secondary brain injury, we should avoid secondary brain injury and we should stop it. And we should not let it happen because it's always preventable. So that you should take into your head very well. How is that? So we have dealt about cerebral physiology, primary and secondary brain injury, pathophysiology. Okay. And there's another thing I want to tell. Sorry. Regarding traumatic brain injury, do you know how to classify it? So classification is done according to the GCS after initial resuscitation. So that part is very important. Classification of traumatic brain injury is done. So listen to this sentence very carefully. Classification of traumatic brain injury is done after assessing the GCS after the initial resuscitation. Okay, so there's a patient who comes with a GCS of 3 and you don't know what has happened. Like you do the ABCD assessment and you find out that the blood glucose is 30 milligrams per deciliter and you give the dextrose and the patients wake up. So without doing the initial resuscitation, you can't actually assess the GCS. That's why this initial resuscitation part is important. So according to the initial resuscitation, after the initial resuscitation, you take the GCS into Glasgow Coma scale into consideration and classify head injury as mild, moderate, and severe. Okay, mild is if the Glasgow Coma scale is between 13 and 15. Okay, moderate is if it's between 9 and 12, and severe is if the GCS is less than 8. Do you all of do you know about the? I think you must be knowing about the Glasgow Coma scale, right? I'm not going to describe it. Like there's a motor component, eye component, and the verbal component. Eye scores 4, motor scores 6, and verbal scores 5, right? Depending on the Glasgow Coma scale, you classify head injury into 3 parts. Bear in mind that it should be after the initial resuscitation, okay? Mild is the 13 to 15, moderate is 9 to 12, and GCS is, severe is less than 8. හරිද? ඒ ටිකෙන් මොකද ප්‍රශ්න තියෙනවද?
No, sir.
අනික් කට්ටිය මේ ප්‍රයිවට් මෙසේජ් එකක් යන්න මට තේරෙන්නේ නැත්නම් ටක් ගාලා කියන්න පුළුවන් ඊළඟට යන්න කලින්. So then we have to deal with the initial management and ICU management. ඒකේ basic principles විතර ඕනේ මේ අර මහලොකු විස්තර ඕනේ හොඳේ. ඊට පස්සේ අර අහන ප්‍රශ්න දෙක තුනකුත් තියෙන එකක් කියන්න. ප්‍රශ්න නමුත්
No, sir.
Okay. So if you are dealing with a head injury patient, say there's a patient who is 40 years, he goes in this is typical scenario. There's a patient who is 30 years who goes in a 3-wheeler and he's a 3-wheeler driver and the 3-wheeler meets with a big lorry. Tipper truck එකක් හැප්පෙනවා. අලි බවුසරයක් එක්ක නැත්නම් ටිපර් ට්‍රක් එකක් එක්ක. And the patient is brought to the Karapitiya ETU by the ambulance අරන් එන patient. And suppose you're called to assess the patient and do the initial resuscitation in the ETU. I think all of you all do the ETU appointment, right? And you must have seen trauma patients, how they are resuscitated. Say this patient, this 3-wheeler driver who is 30 years without any comorbidities comes to the ETU after a head-on collision with a big bowser or big truck. So if you are asked to assess the patient, how would you deal with this patient? වෙනුර කියම්බා වෙනුර දිසානායක කරන්නේ සුපුන් Supun innada? Supun maddu meheva.
So immediately I would assess the patient.
Okay.
ABCD approach, and then I would correct the problems identified in the initial assessment.
Okay.
Airway, breathing, circulation wise, if the patient's airway ensure if the airway is clear, and if not, suck out secretion and otherwise, and put the patient on high flow oxygen and connect him to monitoring blood pressure, pulse rate, respiratory rate, and SpO2, and then if I would assess the patient, and if the patient's GCS is less than 8, I would intubate the patient.
Okay, fine. That's good. So in a trauma patient, as you see, the first sentence should be, I would approach this patient with the ATLS approach. All you know, the advanced trauma life support killer. Mother Anjana sir, ATLS approach to all you know that.
Yes, sir.
Yes, sir.
Okay, so first sentence should be, I would, you can, like, if you want to say it nicely, this is a sick patient, I would approach this patient with the ATLS approach, then I would call for help. ඕනේ කියන්නේ නේ. So that should be the first sentence. If you deal with a trauma patient, in any case scenario, you should tell that I would approach this patient with the ATLS approach and call for help. That should be the main two things to show that you're a safe doctor. So as according to the ATLS approach, when you approach a trauma patient, you must say in airway, C-spine control. I'll approach the airway with cervical spine control, because in trauma patients, until otherwise proven, you must assume that the patient has a cervical spine injury, isn't it? So you must tell that I would approach the patient with the ATLS approach. With regard to airway, I will approach the airway with C-spine control. So how do you do C-spine control? You must do manual inline stabilization. Manual inline stabilization කියන්නේ අද්දකින් විතරක් head එකයි මේ cervical spine එකයි neck එකයි stabilize කරන එක. ඒක දැන් මේ කරලා පෙන්නන්න බෑනේ. ඒක Google කරලා බලන්න රූපයක්. Manual inline stabilization කියන්නේ මොකක්ද කියලා? MILS කියලා. Manual inline stabilization. So by if you are in a like district hospital or a say if you are in district hospital, if you don't have any equipment and somebody comes with an assault with a low GCS, you should apply this manual inline stabilization. Immobilize the head and neck with your hands. So you can ask somebody else to do it, but in order to do it, you should know how to do it, and you should be trained on that. So you approach the patient with the airway with cervical spine control, and you do manual inline stabilization. As you said, you can apply high flow oxygen, 15 liters or a non-breathing face mask, right? Then if you are in a tertiary hospital, like maybe teaching hospital Karapiti, you can apply a hard cervical collar, right? Put a hard cervical collar, and then you put two head blocks on each side of the head to immobilize the head, and you put tapes across the head, attaching the tapes to the blocks, right? You keep two blocks on either side of the head and tape it to the table or the bed, right? So to immobilize the spine, you can do either manual inline stabilization, or if you're in tertiary center, you can put the hard cervical collar, then put head blocks and tape the patient to the head blocks, right? Then with regard to breathing, you do the 4 basic steps: inspection, palpation, percussion, auscultation. Then you exclude life-threatening injuries in the chest, right? Or as well as the airway. So after airway and breathing, what are the life-threatening injuries you exclude? Have you heard something called ATMFC, life-threatening airway obstruction? T is tension pneumothorax, O is open pneumothorax, M is massive pneumothorax, C is cardiac contusion, cardiac tamponade. So after A and B, you do ATEM FC and make sure that life-threatening injuries are excluded, right? Airway obstruction, tension pneumothorax, massive pneumothorax, open pneumothorax, and cardiac tamponade. So after that, you go into C, and since it's strong patient, I'm not going to ask questions, right? I'll just tell, otherwise it takes time. You put 2 in the circulation, you quickly assess the circulation, check capillary filling, assess whether the peripheries are warm or cold, then check pulse rate, rhythm, volume, check whether it's low volume or not. Then you have to check all the pulses quickly, peripheral pulses as well as central pulses. When you check the pulses, specifically look at the peripheries and see whether you can see a distal pulse. Like for example, radial, if there's a big suspect, if you suspect a femur fracture, you can always check the distal tibial pulse and check whether there is adequate perfusion to the leg. So you do the pulses, then check the blood pressure. After that, quickly auscultate for the heart sound, because it can give important clues. Say if there's a cardiac tamponade, the heart sounds can be diminished. Okay. So you do quickly assess the circulation. After that, you do put 2 white bore cannulas. Usually white bore is like less than 18 gauge or more. 18 is green, can remember, and white is 17, 16 is gray, and orange is 14, isn't it? You put 2 white bore cannulas and take blood for all the investigations. You take the full blood count, blood urea, clotting, and blood, most important, blood for grouping and cross matching. Okay. Then if the blood pressure is low, you can give normal saline usually. If you suspect head injury, you usually give normal saline. You don't give Hartmann's, because one thing is Hartmann is slightly osmolality is a bit less, so it can cause cerebral edema. That because of that, you usually don't give Hartmann's to head injury patients. You give normal saline. And if there's massive bleeding, you can always get uncross match blood and give blood for resuscitation. So that's C. Then you move on to D. In a head injured patient, D is the most important. Like one thing is in disability, you check the pupils, right? You check the pupils whether they are equal or not. Then you check the GCS score. You check the motor component, eye component, and the verbal component. Okay. If you can't, there are alternative methods. You can do the conscious level. One thing is GCS score. Do you know of other score which you can assess the the conscious level? The AVPU score.
AVPU.
Okay. The AVPU output is A is alert. V is the patient responds to verbal command. P is patient response to pain, and U is unresponsive. Roughly, if the GCS score is, if the AVPU score is pain, say if it's P, it roughly approximates to a GCS of 8. Okay. AVPU score of pain, say if you do the AVP score and patient response to pain, it is roughly equal to a GCS of 8. Okay, you should know that a little bit. And then you do the GCS or AVPU and record the conscious level of the patient. And then you check the blood sugar. It's also very important. Okay, then you move on to E, expose the patient while maintaining cervical spine alignment by manual inline stabilization or by applying collars, and look for other injuries. You quickly see the patient from top to bottom, and if you want to see the backside of the patient, what can you do? Say if the patient is lying supine and if you want to see the posterior side of the patient, you can log the patient, right? You can't just turn the patient haphazardly and do it. You have to log roll the patient. Okay. So after the ABCD assess, that's the initial part. You do the ABCD assessment as I told. Then during the assessment, you look for reversible causes which can cause secondary brain injury. In after A and B, if the patient is hypoxic, if the saturation is say 90 on air, you can give oxygen. If the patient is having obstructed pattern of breathing, say if they are seesaw breathing, or if there are snoring noises, or there is stridor, you can support the airway. You can do airway opening maneuvers such as jaw thrust or head jaw thrust. You should not do head tilt and chin lift in a trauma patient. And in spite of the simple maneuvers, if the patient is not maintaining the airway, you can intubate the patient. At what point do you usually intubate the patient? Do you know roughly a GCS level?
8 or less than 8?
Yeah, if the patient's GCS is 8 or less than 8, you assume that the patient... What the? Okay, if the patient's GCS is less than 8, you assume that the patient can't maintain the airway, and you intubate the patient. And in breathing, if there is a pneumothorax, you can put IC tube. If there is a tension pneumothorax, you can put a cannula and immediately decompress it. And if there's a cardiac tamponade, you can call the cardiologist and try to drain it. Then if there's an open pneumothorax, you can also drain it. Then if the patient is hypertensive, as I told in circulation, you can give fluids, and if you can give crystalloids or blood. And in disability, you can't do anything much. You can, if the blood sugar is low, you can give dextrose. And you have to expose the patient, maintaining cervical spine alignment, and you have to log roll the patient. Okay. So after the initial resuscitation, if the GCS is low, the priority is to take the patient to a CT scanner, right? By doing the CT, then you can assess the degree of, you can assess the pathology, whether it's intracranial hemorrhage, subdural or extradural, right? So while taking the patient to the CT scanner, you know that all of us know that the CT scanner is a different place, in a different place from the initial resuscitation place. So you have to take the patient carefully, taking all adequate precautions for transport. Okay. ඒටීම්කුත් තේරෙන්න තියෙනවද?
So is there something called CABCDE approach?
Yes. So if say the same patient comes to the hospital and he's like bleeding from the right leg continuously, and you can see there's a massive wound in the left thigh. So in that case, because there's obvious bleeding thing, you have to initially address the bleeding point. So that's how CABC comes. You address the circulation because it's like bleeding the patient to death, quickly apply pressure, or maybe apply a tourniquet or splint the leg, and then you do the ABC. So if you can see that there's something evident which is life-threatening in the circulation, first you address that because it can kill the patient. But in the real life scenario, somebody will be assessing. So there's a patient with a massive leg wound bleeding from the thigh. Somebody will assess the leg wound, and somebody will look after the airway. So it will be like a multidisciplinary approach when you treat a trauma patient in the real life scenario. How's that?
Yes, sir.
Okay. Anything you want to ask from? Is there anything that you want to ask up to now? Okay, so say this patient, there's this head injury patient which I told you, who comes after a collision with the three